Welcome to this video on building advanced cardiac life support team leadership skills. In cardiac arrest situations, bad outcomes happen all too often. The doctors and nurses in attendance, however, they're incredibly well trained and really intelligent. They're all well trained in ACLS management. They make good decisions, the patient gets the right drugs and the right treatment. So why are too many of these patients dying? Well, of course, it's complicated, multifactorial, and I certainly don't have all the answers. But I can confidently tell you some of the things that are not the cause. Our cardiac arrest patients are not dying because the team of doctors and nurses are not intelligent enough, nor because they don't know their ACLS, nor because they lack clinical skills, or because they're just not trying hard enough. We often say there are no easy answers, but in some respects I think that's not true. Many are dying because of delays in initiating treatment. After 40 years of attending cardiac arrests, I am absolutely sure that at least some of our patients are dying because at a hospital code, the medical and nursing staff present are often strangers. They're strangers. They've never worked together before as a team. And when the patient's attending physician finally arrives, sometimes, perhaps often, they are ill-prepared to impose order on the chaos and take control of the situation immediately. If there are problems which can be fixed relatively easily and may save lives, we have no choice but to at least try to fix them. Chest compressions are frequently started almost immediately, but without good leadership, it often takes 10 to 15 minutes from the initially chaotic beginning for an efficient team to evolve. In this interval of 10 to 15 minutes, the myocardium has often already died an ischemic death. Our patients may be dying because our initial disorganization delays effective care, and this is not a local problem. This probably occurs to some extent in the majority of resuscitation teams worldwide. So we need to start high-quality chest compressions immediately, and we need to evolve into an efficient team within the first 3 minutes, which only occurs this quickly if there is a team leader. It's that simple. In a cardiac arrest situation, nothing kills our patients faster than a leadership vacuum. I have held this belief since 1989, and how can I support my utter conviction that this is the right approach? Well, in 2015, the American Heart Association released a DVD to accompany its ACLS manual with a focus on crew resource management during ACLS. If the American Heart Association made a video specifically on this subject, then it's probably incredibly important and relevant. Despite this, unfortunately, even here in the United States in 2021, many cardiac arrests remain chaotic. We have to improve. But where is the potential for the greatest improvement with the least investment of time and money? I believe the low-hanging fruit of future resuscitation medicine is improved crew resource management. We must start chest compressions immediately, and we must organize ourselves into more effective resuscitation teams within the first 3 minutes of the arrest if we are to improve survival. As anesthesiologists at a cardiac arrest, if there is no team leader, it is a priority and our duty to announce ourselves as the team leader, and we have less than 3 minutes to assemble those present into an effective team. It is essential to build a great team, and when the patient's actual attending arrives, they will inherit an already highly efficient, highly functioning team. This attending will usually assume the team leadership role, but some prefer not to be team leader and simply to provide important information to the pre-existing team leader about the patient. If the patient's attending is not in the building, the team leader role can then be assumed by the leader of the Code Blue response team when they arrive at the scene. At the start of an arrest on the hospital floor, usually there is a shortage of staff to whom to delegate, but in our operating rooms, pre-op care unit, the post-op care unit and the ICUs, there is usually no shortage of staff at a cardiac arrest scenario. So, finding 7 people to delegate to should not be a problem. The good news is that rapidly building an effective team is not as hard as you may think. Through the next 10 years or so, you will probably be building exactly the same team every time, just with different individuals in each role. The team leader never does tasks. He or she always delegates the tasks. So This is just like giving a general anaesthetic. Let's start with the induction phase. So, here is how we build the team. The team leader uses the mnemonic CAB, DD, DDD. CAB and 5 Ds. The priority is C for chest compressions started as soon as possible. Simply say, you, please start high quality chest compressions. Then, the responsibility for AB, airway breathing, obviously goes to any anaesthesia personnel present. You, please manage the airway and breathing. Slight hypoventilation is better than hyperventilation. During the 10-second break, stop ventilating and gently palpate the carotid pulse and report return of spontaneous circulation ROSC immediately to me. Then delegate the 5 Ds. You are the defibrillator person. Please get the defibrillator. Bring it into the room, switch it on, charge it to 200 joules, and tell me the moment it's ready. You, please, you'll be the drug administration person. Please draw up 1 milligram of epinephrine, plenty of 20 ml vials of normal saline flush, and 300 milligrams of amiodarone, and tell me as soon as they are ready. Next, you are in charge of code discipline. Please use your smartphone to time 200 high-quality chest compressions. They must be 2 inches deep, allowing full recoil, and these must take no longer than 2 minutes with a 10-second break. We want 10 good chest compressions every 6 seconds. Absolutely, please, never, ever, ever let the breaks, that is, the no perfusion intervals, ever be more than 10 seconds. Ever. You will be the documenter. Please start documenting the times when chest compressions commenced, the timing and dose of every drug and every defibrillation given. Please, would you be the medical detective? Find any cognitive aids available and please give them to me, the team leader, ASAP. Then, find the patient's chart and review his past medical history and find out what are the likely causes of this patient's arrest. If you need to interrogate the computer database on this patient or track down his doctor or nurse and see what they know about this patient, please do it. Finally, you will be the second chest compressor. When the first chest compressor has done 4 minutes, he or she will be exhausted and they will step down and you will alternate with them on a strict 4 minutes of chest compressions each. And when you are both tired, please recruit 2 more people to take your place. This brings us to the end of the induction phase, and now, just like any good general anaesthetic, we commence the maintenance phase. Our maintenance phase tasks are attention to code discipline, quality control, crowd control, communication, and current status, and I will enlarge on these right now. The tasks during the maintenance phase are relatively straightforward and aim to maintain the high quality initiated in the induction phase. These include the 5 C's we've shown: code discipline, control of quality, crowd control, communication, and current status. An example of control of quality is strictly enforced breaks in chest compressions to be no longer than 10 seconds ever. I call this the non-perfusion interval, and lack of perfusion kills our patients quickly. So there must be 200 compressions in 2 minutes, that is 10 compressions every 6 seconds. These must be very high quality, again 2 inches deep on the lower half of the sternum, allowing full recoil. Controlling the quality of the chest compressions requires ensuring an end tidal CO2 greater than 10 millimeters of mercury, and if an A-line is in the patient, an aortic relaxation pressure greater than 20 millimeters of mercury. And of course, with strict attention to avoiding hyperventilation. Crowd control is simply a matter of controlling the noise in the room. The only loud voice in the room should be the team leader, and when other team members need to communicate amongst themselves, they should do so in a very quiet voice. All communication to and from the team leader will be closed loop and will exhibit mutual respect between all team members. In longer codes particularly, it is important to review the current status while chest compressions are continuing. How many 2-minute cycles have we had? How many shocks have been delivered? How much epinephrine has been given? And what was the most recent rhythm? A great way to improve the dynamics in the room is for the team leader to say at this point, "Hey guys, what am I missing? What am I doing badly? What could we be doing better? Does anyone in the room have any suggestions?" Finally, although clinical production pressures within a hospital make this difficult, it's really important for the team leader to try to find at least 15 or 20 minutes when this team can debrief in an attempt to identify areas for improvement. Please remember this: if we do not learn the lessons of history, we are simply doomed to repeat them. Now, in finishing, by definition, Cardiac arrests happen to the very sickest of our patients. These patients deserve the very best we have to offer. Thanks for listening.